Find the answers to questions you may or may not have asked yourself here at Kaleidoscience, Conversations on Cognitive Science. Pain is something a lot of people deal with and live with. And as far as I know, back pain belongs to or is the most prominent type of pain there is, or at least what most people live with on a day-to-day basis. We are today talking to Janosch Priebe, whom I mainly by now know from Instagram from his Instagram account, Dr. Yap, where he does science communication about science in general. But I also knew that he did his PhD, especially on lower back pain. And I'm really excited to have you here today and talk to you.
Thank you very much. Hi.
Okay, to start off, we usually play a little get to know game with our guests. So I would like you to finish the sentence beginnings I'm going to give you and don't overthink it too much. So as a kid, I always wanted to be
A pilot.
A pilot, why?
I think every boy wants to be a pilot in my generation when I was a kid. But yes, it was just awesome. I did my first flight when I was 5 years with my mom. We went to Bali. It was so crazy. It was rather not a club holiday, club vacation. It was really like a bit traveling around. And then I fell in love with the 747 jumbo jet.
That's very cool. And if I was an emoji, I would be.
I don't know what the name of this emoji is, but the laughing emoji with the tears. So laughing so hard that the tears are coming. Yes.
Yeah.
That's very fun. And my favorite thing to do on a day off is
Skydiving.
Skydiving.
Yes, I'm a passionate skydiver.
wow.
Did you just start it by coincidence? Did you want to start it? Or like, I know no other person who does skydiving, so I'm curious.
Yeah, I'm really in love with adrenaline. So I'm riding motorbikes. I like normal diving in the sea, but also in a bit more extreme manner. And then I was told that skydiving is the most extreme thing you can experience. And for people who are addicted to adrenaline, yes, it's just perfect. And yeah, I just like it. There is nothing more extreme on this planet than jumping out of a plane. And so I think for a lot of people, it's not the right thing. But when you jumped off a plane one time, then you really change your level of anxiety or fear towards specific things. Because a lot of skydivers tell this, they always say, come on, I don't need to be scared to go to my boss for a crazy talk. I fucking jump out of planes. It cannot be, it cannot be worse than this.
I don't even know what to say about this. So when you have a day off, you just, if you have the opportunity, go on a plane and really jump from this plane.
Yeah, it's like a club or on the skydive school where also students are instructed how to skydive, and also the tandem stuff is done there. And then yes, in early morning 6 o'clock I go on my motorbike, go the 90 minutes to the skydiving school, and on 9 o'clock, if I'm lucky, I'm in the first load and jump off. So 4 to 6 times a day, and then I go home.
Okay.
That's a lot.
Okay, the next sentence is right now I'm most fascinated by.
Right now, I'm most fascinated by the idea that people can live on different planets, what Elon Musk is doing, so, or he's planning to do. I don't know if it's really a plan or if it's a kind of delusion he's suffering from, but the extra planetary life, I think this is the correct term, is what I'm really fascinated in. Not only because the idea that some people live there, but rather it's the brain again, that the human brain or humans are capable to plan stuff like living on different planets. Even the most intelligent animals beside us are not able to make plans like this. And this is what I think it's really, really crazy.
So it's not really the living on a different planet, but more the thinking about living on a different planet?
creating the idea, which is actually cognitive science, a very crazy cognitive process to make plans, and these are actually one of the, I cannot imagine a higher level of craziness doing plans like this.
Okay, and the last sentence is, I know it's time to call it a day when.
I'm tired and get ready for bed.
Simple answer.
Sorry?
That's a simple answer.
Yeah, it's a simple
just,
one, but
yeah.
Okay, then we want to talk a little more about your background as somebody working in science. What did you study, and how did you like come across the field, and how did you get where you are now?
yeah, so actually, I always wanted to, when after pilot, I wanted to be actually a researcher in the field of neuroscience. So I was fascinated by the brain, and I think in Germany, three studies are suitable for this: biology, psychology, or medicine. Medicine is not a very good scientific education, and I'm not really interested on the cell level. So I didn't pick biology or medicine, I picked psychology. Then actually, I was quite into cognitive science. So I did my diploma thesis actually in cognitive psychology, attentional research. And then I wanted to go a bit more into the brain, a bit more neuroscience, a bit more biological psychology. And then actually there was an opportunity next to or near the city I studied. I wanted to be around the city. Now I moved far away. Um, I studied in Würzburg, and then I went to Bamberg, and I did neuroscientific studies on pain, so mostly nociceptive processing in Parkinson patients. This was my PhD actually, but I always tried to also be still a psychologist. So I also did a lot of eye tracking research on attentional processes when it comes to pain. Did my PhD there. That's why I call myself a neuroscientist also. And then I went to Munich, and for my habilitation, I think we have a lot of German German users of this podcast, so they know what a habilitation is. I went rather in a clinical field, and I did then research on unspecific low back pain, especially its treatment by digital elements like medical apps, like big data and stuff like this. And this is what I did the last years. Always stuck also in neuroscience still a bit, but I switched to a clinical researcher actually. Yeah.
Was it always pain you wanted to do, or did it just happen by coincidence and then you ended up in
Absolutely.
there?
Absolutely. I think most neuroscientists or also clinical researchers end up in a disease or on an issue which they did not plan to be, but it doesn't matter. I can do it with Parkinson, with back pain, with stroke. That's actually not the problem. For me, the brain is interesting, and pain was a coincidence that in the beginning I just thought, you have to beep. Maybe I thought, what the fuck am I doing? Pain, I'm not interested at all. I'm not interested at all in Parkinson. But then I got addicted. I really enjoyed this field. But coming back to your question, absolutely coincidence. Yeah.
Okay, maybe before going deeper into your research itself, can you maybe explain what pain is, and maybe also what's the difference between acute pain and chronic pain?
Yeah, so you started with in the introduction with low back pain, which is a big burden. So it's especially the unspecific low back pain. So what we all know that the back hurts, but there is no specific medical condition which demands treatment, like a tumor or a fracture or something. Um, Pain is actually very hard to define. The IASP, which is an organization, the International Association for the Study of Pain, actually says that pain is an unpleasant experience with an sensory and an emotional or affective part. and which indicates tissue damage or something like tissue damage. So you don't need to have a damage to experience pain. And actually, they also say that pain is what the patient reports. If a patient says, I'm suffering from pain, I'm feeling pain, this has to be respected. I quote. So this is not mine. Yes, but this is what pain is, and acute and chronic pain, it's not a very romantic definition. We call it acute up to 6 weeks, subacute 6 to 12 weeks, and chronic pain from 12 weeks or longer. Um, a lot of people are arguing about this, but this classification is very simple. When you have pain and it lasts longer than 12 months, your prognosis just changes and not to the better thing. This is why we call it chronic pain, but it's only a criterion of time.
Okay.
And so during pain, what happens in the body?
In the body. So what happens in the body? Can I focus on the brain?
Yeah.
So, do you want an example when you have a problem with a bee, or you have a very hot pain, or can you give me a more specific example I can
Okay.
refer to?
So I accidentally touched the hot stove while cleaning something off. What happens now?
Okay, yeah. So for sure, we have some receptors in our skin. Um, Actually, not really pain receptors. This is a myth that we have pain receptors. We have just normal receptors, which also can, when the excitation becomes too strong, um, yeah, can send a signal to the pain pathways, which lead up to our brain. And there are particular areas of the brain get activated. We called it the pain matrix, then we called it the salience matrix, now we call it the pain network. Actually, it doesn't matter. It is just important that the activation of the brain in pain is not specific for pain. This is a very important issue, which also a lot of neuroscience who don't have a good scientific education don't get. For example, when we get rejected or when we get socially included, the same areas in the brain, like we touch a hot plate, actually become active. And what I'm quite fascinated in, and which is also a problem in many pain patients, I talked about excitatory ascending pathways. We also have descending pathways which inhibit pain, also on the spinal level, for example, on the spine. And these pathways become also active when we touch something hot, for example. And in chronic pain patients, these descending pathways, this endogenous pain control system, may not be as active as in healthy people, for example. Yeah.
So
And maybe a fun fact for this: a lot of chronic pain conditions are treated with antidepressants, with the very old one. And this is because these medication activates the endogenous pain inhibiting system. This is very funny, actually.
so just to make sure everything is correct. So we have the excitatory pathway, which is basically the thing coming in. So that's like my body basically letting my brain know, oh, we touched the hot plate. And then we have the descending pathway, which is then the brain deciding how to deal with the pain, right?
This is another aspect of the descending pathway. The first one I talked about is really that the brain inhibits the pain. It regulates down the receptors, it regulates down the spinal level, but also the nocifensive action. So the action defending from the pain is also, of course, a descending process. Yes, for example, a reflex that you very very quickly move your hand from the nociceptive stimulus, from the stimulus which is painful.
You've also mentioned that similar areas or networks get active while being socially rejected, I think you mentioned. Is there correlation, or do we know why that happens?
This is actually how the brain works. So when it's also on my Instagram page that we give the brain too much power sometimes. Not in my opinion, on the scientific opinion, brain activation is always only a correlation, a correlate of something. Um, and if this network maybe is just involved in many unpleasant or very salient events, it just shows that the brain is more complex, that, oh, this is area for love, this is area for hate, this is area for pain. This is actually not possible. But in the end, the brain always does something, and it's always only a correlate, a correlation or a correlate. Yeah.
And for the emotional pain, I would maybe call it, to receive a rejection or something, is it the full network, or are there differences between acute and emotional pain?
Yeah, for sure there are also areas involved in emotional pain, which are rather associated with emotion, like the limbic system or something. But the big ones, the insula, the sensory cortex, and the ACC, the big three of the pain matrix, they are always active, actually.
And I think you already touched upon, just coming back to pain or bodily pain, that in chronic pain, one reason might be that this decrease of the brain might not be working correctly.
The,
Is
the,
that the only thing that happens, or?
no. So actually, chronic pain in back pain, for example, is physically not really explainable, because maybe also take pain after a surgery, after an operation, post-operative pain. After 3 months, actually, there is no physical damage anymore which can explain a sensory of pain. And this is actually one of the the big secrets in pain, that we really don't know what happens in chronic pain. We just know some physiological processes, and one of this is the disturbed pain inhibition. That's why we give medication to increase the pain inhibition, which is actually in our body. But there are also networks, which are like circuits in the brain, which process pain. This is, for example, an issue in Parkinson, by the way, which may also be disturbed or curbed, but we don't really understand the processes properly. That's also why we have so a big struggle with chronic pain, and also with treating chronic pain. But um, how it really develops and how it is maintained is not clear in science so far.
Are there theories that are quite prominent, or is it just a lot of different opinions and ask one scientist and get three answers?
There are, of course, theories. For example, one is the fear avoidance theory, that we experience pain, chronic pain. Maybe our back hurts a very long time, and we try to avoid the pain. That means we get more restrictions in our movements. This, however, increases the muscle pain again. We avoid more, and the movement range becomes closer and closer, and the pain becomes stronger and stronger. But these are rather psychological theories, not really physical or neuroscientific theories. Because actually it doesn't matter which are the brain processes, because they are only correlates. Of course, they can provide hints what may be disturbed, but it's much more important to go on a cognitive, on a behavioral level. For example, we know that people who have a high fear of pain have a much greater risk to develop chronic pain than people with low fear of pain. There are a couple of studies, some were also from our group in Bamberg, that women who get hysterectomia, um, when we did eye tracking, studied with them, and when they avoided negative input on the day before the surgery, they had a worse outcome. So completely avoiding pain. I only look at laughing faces. If someone looks angry, if someone looks painful, I ignore this. I have a worse outcome. So you should not be too vigilant for pain, but you should also not avoid it too much. And these are rather psychological and cognitive processes, so actually more your field.
Um, so you basically say that a reason for developing chronic pain can be how a painful event is approached. So before you experience the pain, your idea of what's going to happen and that it's going to be painful is going to influence the outcome?
That's a very it's a bit an oversimplification. But yes, actually, this is the correct direction. What I meant is that habits towards pain. Am I an avoider? If I have a high fear of pain, am I very vigilant for pain? Is involved in how I process pain, and it also may modulate my risk for developing chronic pain. This was the first thing. And then, of course, attitudes and something we all know, the nocebo and everything. Yeah, it affects the development of chronic pain for sure. But the habits, there's very strong evidence that habits like avoiding pain, but also being too vigilant for pain, yeah, are risk factors, for example. That's what I wanted to say.
Okay. And does the brain response in chronic pain change
Yeah,
compared to acute pain?
yeah. For example, in the laboratory, we did a lot of studies with chronic pain patients, applying them pain in the lab, and for example, the brain response is different. Some potentials are higher, some are also lower, and what we also find in paradigms again that the pain inhibition is not so effective like in the healthy people. This is what you clearly see. Also the nose-offensive actions. So the actions, I put my hand away very quickly. You can measure it with reflexes and something, are also curbed or disturbed in pain patients.
So overall, the responses chronic pain patients show differ from patients or people who do not suffer chronic pain.
Exactly. It's a very, you said it very in general right now, because there are a lot of chronic pain patients. Parkinson patients, for example, are also chronic pain patients, but you find a lot of different physiological responses in chronic pain patients compared to healthy controls. Yeah.
Maybe, but well, I don't know if it's a weird question, but if you have a patient who has, let's say, chronic back pain, and then they experience an acute pain, is both types of pain processed differently on the brain level, or is it the same or similar?
Let's say like this: the brain level on a, normally the acute pain is stronger than the chronic pain. The chronic pain, then imagine you have a, maybe one of you had a migraine attack, or maybe a strong hangover. You're still studying, so you may know this. Yeah, the pain on a scale from 0 to 10, when you have really big headache, can be 8. You take an ibuprofen or you don't, but after maybe one day it's over, so it's okay. When you have chronic pain with 8, you go to a mental hospital. You will not bear this. You are a candidate for opiates then. So normally the intensity of chronic pain is lower, which makes it hard actually to compare it to acute pain. But the chronic pain seems to change the pain system, and these changes are reflected in a different, or in a disturbed processing of acute pain then, yeah, on a physiological but also on a psychological level.
So to me, it seems pretty hard to do research in the area of chronic pain because, as you said before, there are many different ways of many different types of chronic pain one can suffer from. And also, I feel like it must be difficult to build a patient group with criteria and stuff. So, how do you research chronic pain? How do you decide what to research and whom to collect data from? And
So you rather talking about basic level research right now, not about clinical research, because the answer for clinical research is very simple. We have a group, we want to help, and then of course the inclusion criteria are right. um, On chronic pain, it depends on what you are doing. When you want to investigate the development of chronic pain, yeah, the development of chronic pain, you need patients with an acute event. And then you look for patients who have maybe a surgery which is highly standardized and where you know the post-operative pain is high. For example, the hysterectomy is something like this in women. That's the one thing. The second thing is that actually most of the chronic pain studies, when it comes to pain processing, is in back pain patients because there are a lot. That's just what you said in the beginning. If this is adaptable also to other groups, I think it is. But okay, you can also argue we must also include different pain patients. But the big pain conditions, like the classical musculoskeletal pain, like back pain, fibromyalgia, or stuff like this, and then patients with pain which is generated in the brain, central pain, like the Parkinson patients, they are covered by research actually quite good. For me, it was hard to find patients for my neuroscientific studies in Parkinson patients because I wanted only patients with light symptoms. But yes, it worked. And you said you imagine it is hard. I think no one should go to science when you don't expect hard obstacles on your way.
You've just mentioned that I said in the beginning that lower back pain is one of the most common. Is that actually true, or is it just a gut feeling I had?
No, it's very true. It's very, very true. So normally 60% of people suffer back pain once in their lives. And I always talk about unspecific back pain. And what is actually the more striking thing is that we all believe that maybe you have a back pain like a lumbago. For the German listeners, it's called in Germany a Hexenschuss. There is no English word for this. It's lumbago. Um, when you have something like this, everyone thinks after 2 weeks you are fine again, and normally this is the case. So you don't have to do too much. Maybe take a bit of painkiller and then move. So move is the important thing, but making movement possible, it's also in the guidelines to take medication. But we also know that 60% of those people suffering from acute pain today are still or again in pain in 1 year. So this is a really huge problem, and not only for the life quality for the people, but also for economic reasons. We have so much money which we need to spend for pain when the people cannot work, for absenteeism. In Germany, everyone knows that the health insurances pay after 6 weeks when you are sick and something, and these are tremendous costs. And the problem, but when it comes to this, is not that we don't know what to do, but the problem is that there is a lack of guideline-oriented treatment. We have so good guidelines for pain. We can help those people actually perfectly, but it's not done. This is the problem.
And is there any reason why it's lower back pain, or is it just, it could also be upper back pain or, I don't know, knee pain?
Um, in complex patients, there are normally, when you give them, they have to always fill a questionnaire before they come to the lab or to the doctor, and they have to sign on a mannequin where they have pain, and there is actually not a single patient who is just on the lower back. But normally it starts from the lower back, and we don't know why this part is very vulnerable, but it seems to be.
And what are the current treatment options for chronic pain, or specifically for chronic lower back pain?
The evidence-based ones, or what is actually done?
Both,
Yeah.
The
maybe?
first evidence based.
Yeah, sure. Um, yeah, actually, it's what we call the multimodal pain therapy or multidisciplinary pain therapy. And this is actually very simple. Physiological exercise, so physiotherapy or only movement, movement, movement. Psychological exercise, which means stress management, mindfulness, and most or one of also very important, last but not least, psychoeducation, so that you get knowledge about your pain, that it's no problem, you don't have a damage, you can move, you can also move when it's painful, it's no problem. These are the three pillars actually. Um, and you should do it when you have just an acute pain, but also for the chronic patients, of course, they get a bit more psychotherapy, for example. But actually, this is all they need to do, the multimodal pain therapy. The problem is that there is a lack of treatment capacities in Germany. And we also know that there is, treatment which is not evidence based, which is just ridiculous. For example, what is very very often done is imaging of the back. So you put the people to the MRI to see if there is a damage or something. And we know from studies that when the general physician, so the family doctor, excludes red flags, he asks you, do you have pain on different space? Did you have maybe an accident with your motorbike or something? If there is a fracture, there is no better outcome for the patient to do an imaging. Additionally, this is done a lot. It costs a lot of money, and it opens the gate to hell, I always say, because you always find something on the spine which is independent from your pain, but you still get the surgery, and then you are in the wheel and you never get out this again. This is a big problem which costs a lot of money. Then medication which is not indicated, for example, paracetamol. Ibuprofen is okay, and even opiates if the pain is so strong that no movement is possible. Doing electric stuff and something, acupuncture, for example, is in the guidelines now. You can do if you want, but actually it doesn't matter. Yes, this is a problem. Um, what was the question? Ah, the treatment options.
Treatments.
Yeah, actually there were some treatment options. Now I told you so.
I feel like whenever it comes to bodily things, people nowadays tend to say it always has to do something with nutrition.
Hmm?
So, like telling people to eat less inflammatory foods, to focus on what types of foods you intake, etc. And I feel like there also the opinions are quite divided on in how far that is something you that really helps or doesn't. So is there anything known about specifically chronic pain and nutrition, or is it just placebo again, or well, just wanting to do something?
Yeah, so first of all, when a patient or an individual is in a chronic condition, I would encourage him to do some try and error. If someone thinks that when I don't know, when he eats red meat the pain gets worse, avoid red meat. Oh my god, do it. So this is very important, first of all, to empower and encourage the patient to try and to find out what is good for him. In pain related to inflammatory conditions like rheumatism, there is light evidence that a specific type of nutrition avoiding inflammatory food may have small effects on the pain, but it's not really defined what means inflammatory food actually. So the effect size is small, and it's always hard to control for confounders in nutrition studies, because a person who eats shit every day is more likely to smoke or to drink or something, not doing very much physical exercise. In back pain, I don't know any specific studies which show a benefit, but for sure, a healthy lifestyle in general is always good for patients in any chronic condition. And there is also um, um, nutrition is also a part, but this is what I also always say on Instagram. Healthy nutrition is very easy and everyone knows how it goes. The problem is that we don't do it.
Okay, coming back to the topic before, when you say there are known science-based interventions, but they are never used, do you think it's like a money issue, or do you think it's a knowledge issue, or what do you think this is due?
So it is a knowledge issue. There were also surveys in general physicians in Germany about their knowledge. It was a shame. And actually, it's not really a money issue, because we spend money for much more expensive treatments which do not work. It's rather an issue of capacity also, because um, in Germany, when you need physiotherapy, for example, you get six sessions, each 20 minutes, and then you have to do it at home and your own. No one does it, let's be honest. Yeah. I think we all have prescripted stuff from the doctor, which we never did at home. There are specialized pain centers, but they are rather for severe cases. And this brings me to my postdoc research. Actually, this was the thing that the digital media, the digital elements, have a strong opportunity to close this gap, because the stuff I told, physical exercise, psychological exercise, and education, can be perfectly delivered by an app, for example. And this is the problem, that we are not able to provide it on a wide range, independent from time and space. And the digital world makes this possible.
So you did this work on an app, right, for specifically lower back pain?
Yeah.
Was it that people could just, well, how was it checked medically that people, or that the interventions worked? What types of interventions did they get, and how far did people actually do them? Because as you've just mentioned, I also quite often got something, or I've been told to do something and I've did it for a week or two and then I stopped.
Yeah. So first of all, there are many apps, and I don't have any connection to this app from an economic point of view. But actually, we did a more comprehensive approach, where the app was embedded in a guideline-oriented, general physician-centered treatment algorithm, and the app was one part of this. We also had digital consultations with pain specialists and big data approaches, but the app was actually the main point. But there was also always a doctor involved. That's very important. When it comes to investigate the validity of, or the efficacy of such an app, you have the big advantage that it collects a lot of data. So the patients have to enter the pain level every day, actually. So you have a great curve of the pain development. And this is also because some people are scared of apps. The apps also monitors this and says, oh, 2 weeks you don't improve, please see your doctor again. We will just don't let you into this app till you just gave us a check mark, I was at the doctor, for example. And we did a lot of studies. We did studies just on the data the patients enter to the app, but of course also, the common randomized controlled trials, where the app ran against the standard care, which means physiotherapy, and also the bigger concept, and the digital approach was always superior to the treatment as usual, because I think it's just because the patients, they train more, they they spend more time actually in managing their own pain. They get motivated by incentives like gamification or something. They can connect with other patients. Yes, and this is a great opportunity. And right now in Germany, we have the DIGAS, which is something in English when we say digital health applications, which can be prescribed by the medical doctor or the psychotherapist, and which also the health insurances pay for. And they are growing and growing. Right now, there are nearly 50 for completely different diseases, and back pain is one of the actually the perfect disease for treating it digitally, because it's very simple. You have to exclude red flags, fracture, tumor, inflammation, or something like this, and then it's just train and don't worry.
Mm, it's maybe one of the benefits of an app that it also reminds people more, because when I just imagine I go once a week to physiotherapy, and or maybe twice a week, I'm told, well, first I get maybe some treatment or do some exercise there, and I'm told, well, do that at home each day. But I don't get daily reminder unless I set a reminder on my phone. So then I guess an app is an easier way of reminding people, or what is the effect why people might be following it
Yeah,
more?
that's actually really funny, because the people, we did also some surveys with them, and they don't want reminders. The app is not, one guy tried wrote us, the app is not a policeman. Yeah, so we don't want a police app. But I think it's just because the training program is tailored to the patient every day, completely new. You can interact with the app. I don't think that it's really a reminder. And they can also not train if they don't want. This is actually very funny, because it is not like that people, the more you train, the better you get. This is very funny. We found that the patients find their own dosage. There are, for example, patients who train 2 weeks and then they are perfect and they stop. And there are patients who train 3 months till they get better. So the patient actually knows what he does. And maybe we really should empower him. And maybe it's also not only that I train and I don't go to the physiotherapist. Maybe it's also I don't train because I don't want now, but I go to the physiotherapist because I have an appointment. So it's just putting the patient in the center. And I think this is the main point in this digital world in the healthcare system.
And also maybe increasing the feeling of self-efficiency a bit. So because when I feel that I have full control of what I'm doing
Exactly.
or not
Yeah,
doing,
that's what I
it's just,
yeah,
yeah.
that's what I meant with empowering. Exactly, this is self-efficacy at its best.
Did people tend to follow? Or like, no, how you mentioned that the app calculated the recommendations or the training things each day. Was it based on feedback the users gave or the
Yeah,
patients gave?
yeah. Rather,
Okay.
especially they are asked, for example, if they enjoyed the exercise program, but it's also what they enter, how the pain develops. When you have a hard training yesterday and today you have a pain 8, then the app just goes down a bit and goes a bit more slowly. And you also can say, oh, this exercise, I really like this, but this one I don't like. And then the program is also always tailored every day. And it's also possible to correct the patients. The camera of the mobile phone just tracks you, and then the app tells you, oh, go a bit deeper in the squat, for example. So this is also important because many people are scared that they do anything, that do something wrong. And even worse, the pain, which is actually not necessary because nothing can happen, but it's a good security thing for them. Um, to think that they do the correct movement.
And you also said that the app had like gamification elements. Like, how would you implement gamification in a context like that?
Yeah, I think gamification is very simple. It's, for example, that you get a good feedback when you train 7 days in a row, for example, or when you collect, for example, you say, come on, let's decrease your pain in 4 weeks from now 5 to 2. And then they get a smile or they get points or something. That's like operant conditioning. That's actually ridiculous. But even adult people, we know it from the laboratory, we react to a smiley which is provided on a desk, actually, which is a good feeling. And then yeah, we get conditioned, and this works very hard, very good. When I saw this the first time, I also just thought, come on, it's not possible to get people with that. But even they give feedback, oh, the gamification was perfect, I always try to get smileys and something. That's how we are.
So from the patients, from the users, what was the most unexpected feedback you got where you were like, that wouldn't have been something I would have thought about before, but it might make sense or might not make sense even?
Actually, there was not a weird or funny feedback, but there was one feedback which I thought, oh my God, what's up with this guy? He just said, I don't want to miss this app anymore. And he wrote this in a very pathetic German sentence. But this was the feedback I actually know. For the patients, it was quite normal. Um, it was rather that the medical professionals were not too happy in the beginning because they thought, oh, this doesn't work. My patients don't want this. And research shows that the patients want it and the professionals are actually pressing the brake all the time when it comes to digitization.
Did they change their point of view over the time, or were they the whole time like, no, patients don't really want that? It's
Yes,
just
our last I think it was a paper in 2022 we published this, and there it was quite okay. So it changed over the last 4 years. The study from 2018 was not from us, but there was a thing happening which were actually perfect for the for digital medicine. the COVID pandemic.
Hmm.
Actually, it was just crazy because then everyone needed digital solutions, and this was a boost also in Germany that we thought, oh, okay, now we should. But in Germany, the digital healthcare system, it's quite funny here. We when you look at newspapers, and there is maybe an article about digital medicine, you see two doctors with a telephone. This is digital medicine in Germany. In other countries, is it in New York City? There is a brain surgeon, and he operates a guy in Tel Aviv via robot. This is digital medicine in other countries. Yeah. So of course there is a guy doing the narcosis, and there are nurses and something, but the surgeon is in New York and operates someone in Tel Aviv. There is a video actually. And in Germany, for us, digitization is phoning and not speaking face to face. And in Germany there is still a long way to go. Also, and this is my last point to this issue, because of the data issue in Germany,
Hmm.
we are very into data safety. In the USA or in England or in Israel, they don't give up about their data, because it's also a completely different security situation. But this is what stops in Germany a bit. But right now, it's coming, and I think it's great.
Maybe coming back to the brain a bit. After doing or when you did the patient study, did you also look at brain changes in how far they experience chronic pain, or did you just rely on their feedback on their pain?
So we are just
Losing
leaving the
words, but yeah.
field. We are leaving the field of digital medicine right now.
Yes,
Yes.
yes.
Okay. Um, no, we did not do studies which monitor changes in the brain over time of the development of chronic pain. And I'm not aware of studies actually which have done this, because you can do it also just like comparing two groups and maybe you take people with 1 year pain, so early chronic, and then after 5 years you just compare them with a control group. So um, I don't know how the development goes by exactly.
I was mainly asking because I was wondering if a patient had chronic pain for, let's say, 10 years, and then the chronic pain improves. Does the brain also change back to well, to a not chronic pain brain, or does it just stay the same in pathways that have developed?
Now I understand what you mean. Yes.
Hmm.
Since we come back to the discussion if it's a cause or a correlate, we said it's a correlate, and of course it changes back again to normal processing of nociceptive input or of painful stimuli. However, all the people now say, "Oh my God, that's stunning! That's so amazing! The brain is so amazing." No, this is just logic, because it's a correlation. Of course, the brain response is also normal, but you can illustrate that actually the pain doesn't matter. When the patient says, I don't have any pain, it's fine, and the brain would be still show abnormalities, no one would tell the patient it's not possible, your brain is still abnormal. Yeah, it's stupid actually. So it's absolutely, for me, absolutely logic that the brain changes back. And of course this is cool, and we have to do research on this, but this is not too fascinating, because this is just a correlation. Of course, there are pain conditions which really, really develop in the brain. The central pain I mentioned in Parkinson patients, but there are specific lesions of particular pathways which then lead to painful sensations. But this is only a very, very slow percentage of patients.
With the digital health interventions, um, what can you see how they might become even better, or how other digital health interventions apart from apps could be developed for pain and chronic pain?
Yeah, so your question refers to treatment, because the treatment, I think apps are the perfect way, because it's better to have an app on your mobile phone than to go to the internet browser and sit in front of your computer, for example. But other digital elements which are used are the big data issue, which is also a revolution, because when you have the data from hundreds of millions of back pain patients, you can tailor the treatment of a new patient perfectly, because you know what helped a patient which is very similar to the new one. Um, and of course, just the connection of different specialities, even in more complex diseases like pain conditions, like neurological conditions, psychiatric conditions. This is also a chance of digitization, which is only an indirect, which has just an indirect connection to the treatment of patients. But for example, in Germany, we struggle with the shared case report form. So when you go to your dentist, he cannot take a look at your file where all your diseases, for example, are in, because of data security issues. But this is also something which can really be a revolution for the treatment, when you don't have to tell, yeah, and this was there, and I had this, and there is this, and yeah, I take one of the blue pills and one of the red ones, I don't know what is the dosage and something. And this also would be very easy, but for the treatment directly for the patients, I think apps are the perfect way.
Okay. So to come to the end question, um, which role would you say does cognition play in your research?
So, my first steps in research, I told you, was my diploma thesis in cognitive psychology, and there I investigated spatial attention. So, actually, I have a direct role of a very important cognitive function. Um, in my present research on pain patients, I just talked about the cognitive mechanisms which are involved in pain, like attention to pain, avoidance of pain. Um, but I really have to admit that cognition in a direct way is not an issue of my research at the moment, because it's dry clinical research, which actually is also cool when you did neuroscience and cognitive science, just to have two, I always want to say bad words when you have to beep, but it's where you have two study arms and you just compare them. And actually, this is also awesome. So it's fine for me. I'm really in love with cognition, but not to have a direct relation. And I don't want to construct one right now. So not really. I'm so sorry.
No, but I think it's fine. I mean, avoidance and also attention playing a big role in your research is a good connection to cognition.
But
So,
it in my present research, it does not actually.
okay.
That is what I mean, because
Okay.
it's a dry clinical studies, very clean, two groups or four groups, and you compare them. And in clinical studies, you are not too much interested in the processes. You just want to know in the end which one is the better treatment. Of course, you have ideas about the processes, and this is really what I enjoyed after my journey through cognitive research and neuroscience. When it's the complex thing then is the study design and everything, but your results normally are very clear. In cognitive science, you have results, and then you some data, and then you okay, what is the theory in the end? And the
Yes.
theory then, most of the time, is a ship with wheels and a tree on this, and you have to tell the people that this is something really new, cool thing. It was so in my when I had to interpret the data of my PhD. It was so, it gets published, but I still get it that they believed me, that this is possible. Because I had so many physiological data, and then it was like a puzzle to put something together. Okay, this connection is curbed, this connection is disturbed. And then you really enjoy when you go to clinical research where processes are not too interesting. But in my heart, I'm still into cognition. Yes.
When a person has listened to this podcast episode, is there anything they should definitely remember in 2 weeks?
Pain patients who listen to this podcast, and what you should remember is that there is always an improvement which is possible. Don't be afraid of your pain and get empowered. And other people should just be reminded that research or science is the best thing on this world, besides skydiving.
Besides, okay. Thank you so much for your time and for talking to us here today. And yeah, I really enjoyed our chat. It was
I really enjoyed the conversation. Thank you very much.
Thank you so much for coming.
You've listened to Kaleidoscience, Conversations on Cognitive Science, hosted by Elisa Palmer, Sönke Löw, and Sophie Kühne. Produced by Clara Kühne, Imogen Hüsing, Elisa Palmer, Leslie Volk, Sönke Löw, and Sophie Kühne. Produced in collaboration with the Cognitive Science Student Journal. The music was produced by Jan-Luca Schröder. The logo was designed by Annika Richter. Thank you for listening and joining us on our journey through conversations on cognitive science. This podcast is not sponsored and does not give us any financial profit. If you wish to support us, the most effective way is to do so by leaving us an up to 5-star review on your chosen podcast platform and following us on Instagram. You can reach out to us via mail, comment on YouTube, or message us on Instagram. We are always happy to hear your feedback. Thank you again for listening to us and for your interest in science. If you have any questions regarding this episode or any of our other episodes, feel free to reach out. You can reach out to us via Instagram by sending us a direct message at kaleidoscience_pod or write us an email at kaleidopod@us.de. You can find both links to our Instagram and also the email address in our show notes. We do read all your comments and will also reply to you as soon as we can.